You're listening to Mistreated. I'm Nam Kiwanuka. In September, Donald Trump, the president of the United States, sparked a public health crisis when he claimed there was a link between the prenatal use of Tylenol and autism.
The FDA will be notifying physicians that the use of acetaminophen during pregnancy can be associated with a very increased risk of autism. So taking Tylenol is not good. All right, I'll say it. It's not good.
Governing bodies for obstetricians and gynecologists in the United States and Canada were quick to respond, saying the evidence presented was weak and that the links mentioned have been consistently refuted by the scientific community. And the Food and Drug Administration, a United States regulatory body which ensures the safety of medications, said the next day that it, quote, remains reasonable for pregnant women to use acetaminophen in certain scenarios. They went on to write, quote, it is important to note that while an association between acetaminophen and neurological conditions has been described in many studies, a causal relationship has not been established, and there are contrary studies in the scientific literature. This whole situation makes me so uneasy because not only is it going to confuse more people, but it puts the onus yet again on mothers. Women getting pregnant is not new, yet there are very few medications that women can take safely while pregnant. Women were excluded from clinical trials until 1993 in the States and 1997 in Canada. Millions and millions of women have given birth to at least one baby, yet pregnant women are routinely excluded from clinical drug trials, which test the safety and effectiveness of medications. Keeping pregnant women out of trials may be to protect them and their unborn babies, but how are we balancing that risk against other long-term risks for both mothers and newborns? If you're not testing the medication on pregnant women, how do we know what works and what doesn't? What is safe and what isn't? It also allows for fewer options and leaves women to potentially suffer during pregnancy for no reason. And if you have a pre-existing condition when you become pregnant or need medication for migraines or a fever, then you're left with the weight of making a decision for your health versus the health of your baby without reliable medical research. I don't know any mom who wouldn't suffer if it meant that their baby was healthy. And now this. I can only imagine the guilt and confusion that moms who have taken acetaminophen must feel following these very public announcements. Joining me on the podcast today are Dr. Rebecca Titman, a physical medicine and rehabilitation specialist, and Dr. Najla Tabbara, a perinatal pharmacist. They work at Mount Sinai Hospital in the Pain in Pregnancy program, a one-of-a-kind group in Canada that helps to manage pain during the perinatal stage. With our guests, we're going to explore the scientific standards that determine the safety and risk of medications during pregnancy, and we'll take a close look at key studies focused on acetaminophen, including their conclusions about its safety during pregnancy. They join me now. Rebecca Titman and Najla Tabbara, welcome to the podcast.
Thanks for having us.
So, Rebecca, how did you get involved in this program?
I actually had my own experiences of pain during pregnancy. So I was in the fourth year of my 5-year residency, pregnant with my first daughter, and I, started to have pelvic pain, and I, was trying to do, what I could and stay active and everything, but it got to the point where, I was having a hard time, doing my work, exercising, getting dressed, like that terrible feeling of standing on one leg when your pelvis is hurting is awful. So I went to my excellent prenatal care provider, and they were kind of like, well, yeah, you're pregnant, this is just part of the package. And it really just made me think, like, when else do we do that? Without a history, without a physical exam, and without any kind of general, recommendations. When else do we do that other than during kind of pregnancy?
You were basically, the message was just kind of suck it up.
Yeah. Exactly. Yeah.
We're kind of hearing that same message, but we're hearing this from arguably the most powerful person on the planet, the President of the United States. The White House is saying that there's a link between acetaminophen use in pregnancy and autism. Pregnant people are being discouraged from using Tylenol. I should also note that Tylenol is one brand of acetaminophen. Is Tylenol safe to use during pregnancy? Najla, I'll pose that to you.
So what we do as healthcare professionals is that we look at the available evidence and assess, is it safe to use? Is it effective to use? Is it the right medication even to use in pregnancy? One of the challenges we have in our scientific community is that there's limited data for medication use in pregnancy. But when you have a pregnant person who requires or would benefit from medication, you can't exclude them just because we don't have the evidence.
Why is there limited data around pregnant women and medication?
So usually how we study new medications or medication use in most conditions is we do clinical trials. And what happens there is that people participate in a trial and we will monitor them for the efficacy, for the safety. Now, most pregnant individuals are excluded from clinical trials for a variety of reasons. They could be concerns of how is it metabolized or how is it processed in a pregnant person. It's different than the general person. But that's, in recent years, is a lot that's being challenged and say if a pregnant person wants to be involved in a clinical trial, they should be given that option to do that. So when we don't have that type of data, what we end up having is observational studies. So we study women who have been exposed to the medication during pregnancy. There have been some studies that show there is a link between acetaminophen and autism or other neurodevelopmental conditions. The issue with those studies, when we assess them, they are usually of lower quality. They're not looking at how much acetaminophen was used. There are reports of saying, oh yes, I do remember taking one tablet, or I remember taking a couple of tablets. And we know that self-report of medication use is usually not very good. We also don't know how long they were using acetaminophen for. And then there are some other factors in some of these conditions that were not accounted for. So genetic conditions, familial and environmental factors that were not accounted for those in those studies. So the more recent studies that have controlled for those have not found a link between acetaminophen use and those conditions.
I should also mention that the government of Canada is not saying the same thing as the White House. The studies that are being cited by the White House include studies from organizations whose names carry a lot of weight, like Harvard. But there was one very large study from Sweden that involved 2.5 million children that says there's no correlation between acetaminophen use and autism. But when you hear Harvard, I mean, it's Harvard, right? How do you help patients understand what these studies have concluded?
What I would typically say is the study that you refer to, the study in Sweden, really had 2.5 million kids, sibling matched, right? So we're really trying to control for those variables like genetics, household kind of influences, that might impact a developmental disorder. And that study, when you controlled for all those things, didn't find the association there.
We should say that they had siblings from a family where when the mom used a Tylenol for one child and didn't use Tylenol for the other
Exactly.
one, right?
Yeah. So with those studies kind of takes out that association. That is really reassuring to me, especially in such a large group. I will say, so when you read the studies, the one from Harvard, at the end of the article, it does say the recommendations from this are that we use medications when they're medically indicated at the lowest effective dose for the shortest duration that it's needed. And that's how we prescribe medications.
So help us understand more, I guess, what acetaminophen does. What do you use it for?
Yeah. So clinically, we use it for fever and pain, right? And when it comes to, my bias as a pain specialist, I'm not an obstetrician or a family physician, is that we need to treat pain too. And a pain plan is never just medications. We spend a lot of time talking about, what is your function like? How can we help you with your movement, physical activity? stress reduction, talking about your sleep, how from a holistic perspective, can we change and modify your day so that you're not experiencing so much pain? And medications are only a part of that.
The recommendations that come out from our medical societies and healthcare societies are saying that acetaminophen is the safest medication to use for fever and pain in pregnancy, but consult your healthcare provider because you need to make sure that it's the right medication for you as the pregnant person. And one thing that's not getting as much of a highlight recently is what happens when you don't treat pain and when you don't treat fevers.
I was going to ask you this because the minute that I found out that I was pregnant, I was like a bat out of hell. I was like, okay, we're getting rid of this, we're doing this, all these, I was nuts. Yeah. And I think a lot of, because you understand that you're so important to your child that's growing. You have to do everything. Mm-hmm. Stop drinking coffee. My gosh, I was not a nice person. Give up alcohol. No sushi. Oh my God. What do you think? But you try to do everything. And I think sometimes too, because you feel that pressure and that guilt, even if you're not feeling well, you kind of push that aside. I'm like, well, I can't take any medication because I want to make sure that my child is okay. So when we would say a pregnant person has a fever, why is it important for them to take medication to control that fever?
So when fevers are not managed in pregnancy, in the early stages, it's been associated with miscarriages, and then the pregnancy as a whole. Because when we're caring for the infant, mom's health is baby's health. Mm-hmm. If we're not caring for mom appropriately, that will have impacts on baby. So if we're focusing on pain, for example, not controlling pain can result in anxiety, depression, lack of sleep. And how do we usually manage these conditions? Sometimes we prescribe medications for them as well. So if you're not prescribing for one, you may be prescribing for another one. Mm-hmm. So our care is really individualized to the person, and not every solution is a medication. I myself, as a pharmacist, people may think that we always want to prescribe medications, but that's not true. Our first thing is to assess the patient, and in conjunction with the healthcare team, is a medication needed? Mm-hmm. We call them non-pharmacological strategies, so things like rest, stress reduction, let's say hot or cold compresses. Those are usually our first line options. Mm-hmm. Once those have been tried and are no longer effective or not effective, or if the severity of the condition requires a medication, that's when we think about medications. It's not the first thing on our mind, but we need to advocate for our patients because they don't deserve to suffer simply because a blanket statement of don't use it, it's not good for you.
Yeah,
Rebecca? It's more nuanced.
Yeah, agree. I think it's the people's stories that always strike me the most. People cry in my clinic all the time, when we're talking about unmanaged pain and that guilt, like you were saying, the responsibility of carrying a child.
It's daunting.
Yeah. Right? But, people who aren't able to work, and maybe they need to work to be able to qualify for EI or to support their parental leave, telling them to, just tough it out, isn't really fair. Or, the one that breaks my heart is not being able to pick up your toddler because you're in so much pain, and, to take that tool of, taking Tylenol or acetaminophen out of their toolkit to support them so they can carry their toddler. It's not based in science, and it's not fair. It's not fair to them.
Okay, I want to come back to that part about moms. Okay,
yeah.
How do you pronounce it?
I keep repeating it in my head. Acetaminophen.
I've been saying acetaminophen.
Yeah, you got it.
I say acetaminophen too. Yeah. So I think we're stressing the different parts of the word, which is fine as well.
They're all correct.
And it's also known as paracetamol in the UK.
Exactly.
Other parts of the world, yes.
Yeah. But, this conversation also implies that women aren't already doing enough.
Yeah. Mm-hmm.
And when you are dealing with pain and you have that daunting responsibility of taking care of an unborn child, what do you think this is going to do to individuals who will be in that situation where they are experiencing pain, but now that little nugget has been planted?
I mean, in speaking with my obstetrics colleagues over the past week, definitely there's a lot more distress, a lot more questions, a lot more, probably more pain, more sleepless nights around this kind of new information or new, I guess, emphasis on the information. So, and I think again, it just adds to that stress, that daunting task of looking after your baby when it's again not based in the literature that we have. So what I'll typically say to people when I'm counseling them, and this is like, Tylenol is first line. This is what we have for medications. It is safe to take when you need it, right? And then I'll typically say, so when you go home and Google it, like, this is what's going to come up, and this is why I don't think that is something that you need to lose sleep about. Don't feel guilty about taking it, because you need to function. Your health matters, and you are doing what's best for you and baby in treating your pain and your fever.
And Najla, you said before that when someone comes in, it's not medication the first answer.
Yeah.
You do provide, you offer other treatments.
Absolutely.
So if you could just answer this clearly for us, just so if anyone's listening and not sure, are there any times where using acetaminophen could cause harm during pregnancy?
So nothing specific to pregnancy itself. There are conditions for any adult that they should not use acetaminophen. So if you have liver problems, you should not use acetaminophen. But there's nothing that being pregnant adds to change our recommendations. In fact, we recommend acetaminophen to non-pregnant individuals all the time as well as a first-line pain reliever.
Why?
Because it is the safest to start with. And then we always assess. Rebecca and her team may assess what type of pain is it. Mm-hmm. Usually for minor pain, acetaminophen is the go-to medication choice. But if it's a musculoskeletal pain, if it's a neuropathic pain, then we have other alternatives to use there.
I'm going to admit something that is quite embarrassing, but I didn't understand how little I knew about my body until I became pregnant. Mm-hmm. For example, where my uterus is.
Yes.
Yeah. And I say this because I just didn't learn a lot about my own body growing up. Why do you think there's this general lack of knowledge about what medications you can take during or even after pregnancy?
Mm-hmm. So I think it all goes back to, lack of data. And that generally, pregnant people are omitted from research, and we don't have the same kind of randomized controlled trials that we would in other populations. And it's not necessarily completely inappropriate. You'd have to, modify, your studies, but we need more data. We need more research. Even, why people get pain during pregnancy. We don't fully understand why some people, are running the marathons in their third trimester and others are in significant kind of pain early on. Aches and pains in pregnancy are common. Listen, your
body's changing.
Yeah, you're growing a human. It's a lot of work. So it is common, but it still deserves to be acknowledged, particularly when it's impacting your function, right? So if you're having a hard time getting dressed, if you're not sleeping, if you're not able to work, if you're having, if it's having an impact on your mood, then definitely people should be talking to their care providers. And just kind of a shout out to our pelvic health physiotherapists who have kind of been owning this space for a while and are huge advocates in the area too. So it's not necessarily, again, that it's normal, but having, severe pain that's impacting your function, definitely you should be talking to somebody about what you can do. I never promise I'm going to make people's pain go away, but I think just the kind of being examined, like having someone, touch you and say, like, your hips are moving nicely. I don't see any issues with your nerves. I think that's a really therapeutic part of what I do. And just talking about, what we know about pain during pregnancy, usually it does get better. That education piece is really, really important. But I think, we really do need to encourage women to speak up and say, I'm having pain. This is affecting me. What can we do about it?
I think even just in our day-to-day, if you are having pain and it's just impacting yourself alone, you kind of try to figure out how to manage it. Yeah. And we've talked about if you are pregnant, you're more aware of it's not just you that's being impacted. To me, anyway, it kind of feels like women are now being put in a position from the White House. It's like it's taking away a tool women could use to feel somewhat healthy during the pregnancy.
Control of their own well-being.
In control of their own well-being. And we were talking before we recorded how you've actually shifted from saying drugs to medication. I wondered if you could talk a little bit about that, because people are always trying to do the best with the information that they have. But now it just kind of feels like it's a little more mucky.
Absolutely. I think my personal shift is that when we use the word drug, they may think of illicit drugs or other substances. But medications are just one piece of a care plan. Why are we taking away medications or other tools from them, let's say physiotherapy, simply because they're pregnant? That's unfair. Just what is wrong with pregnancy? It is many women become pregnant throughout their lives. We were talking about acetaminophen earlier. 1 in 2 pregnant individuals use acetaminophen. So now with all of this new news, what is that shift going to be? And how is that actually going to impact the health of our patients at the end of the day?
That makes you worried.
Yes.
In what ways?
We worry about untreated fevers, untreated pain. The misinformation causes doubt and makes them feel guilty that they are maybe pregnant. Like, what do we say to a person who now has a 3-year-old who took acetaminophen in pregnancy? They may be having a lot of thoughts and questions, and it's unfair to put them in that position. And I will say that we're constantly doing research. We are always evaluating new evidence. If there's a need to update our recommendations, as healthcare professionals, we do that. So with the evidence that we have today, we are offering our patients the different modalities to manage their pain. And that could change when we talk to, if we were to reconvene in 5 years' time, we may have different recommendations, but we're always learning, and we're learning from the data, and we are lucky to learn from our patients and our pregnant individuals every day when we work with them.
Part of your work with Project ECHO is also educating healthcare workers. What do they want to know about women's pain?
Yeah. There is definitely a thirst for knowledge. I think we've seen that people just want to know more. You can sense that everybody feels uncomfortable supporting pregnant people and, scared. I think pregnant people scare people, in the emergency room and family physician clinics. So people are really thirsty for the knowledge.
Why do they scare people?
Because we just feel so limited. I think, we don't get a lot of training in medical school, particularly around like pain management in this time. And you're looking after 2 people, right? Not just one. So I think, people often just get a bit scared. I mean, I hear it all the time, and patients be like, or people with chronic pain, they get pregnant and like, well, my pain specialist won't see me anymore. My therapist won't see me anymore. They're not comfortable dealing with me while I'm pregnant. So, what do I do?
That's so upsetting to hear, because we also hear conversations around the other part, like when you're in menopause and doctors not really knowing what to do with you. So that's so so upsetting to hear.
So the desire for knowledge is there.
Yeah.
Absolutely. I think a lot has changed over the past 5 to 10 years. The desire is there. It's just finding the tools, the research, and getting the information out there. That's really important, which is what we're trying to do with Project ECHO.
It's great that people are excited to know this information, but it sounds like there are gaps in women's health pain management that's missing. Why is that?
I think there actually is gaps in women's health across many conditions, not just pain, unfortunately. And that stems from the systemic exclusion of pregnant individuals in research. And there's been a shift in an awareness in recent years of the importance of studying medications, interventions, other modalities in pregnant individuals. I was going to say in our Pain and Pregnancy ECHO, we get questions from other healthcare professionals that may seem run-of-the-mill to us, but it really is highlighting the gap in education. And if I were to speak about medication specifically, when you go to look at an information sheet for a medication, it'll usually give you what it's used for, when you should expect a benefit, the side effects, and there's always an other category. And the other category is for children, for women, pregnant women, and then for now geriatrics, which is getting more and more popular with our aging population. So we usually think of all the conditions, the assessment, the treatment, and then we go, oh, but now you're pregnant. What do I do? So I think that's what Rebecca is referring to. We usually think of pregnancy as an afterthought, but then when it's right in front of you, you go, okay, well, I actually need to assess you as a pregnant person with a growing fetus.
I was just going to add, I mean, I think women's pain in general is just incredibly underfunded. Like women, outside of pregnancy have been excluded for a long time too, yet pain disproportionately affects women. So I think just a lot of, our research has been really geared towards men, and again, changing, but it takes a while for the research and the clinical practice to catch up. So there's a lot of gaps just in general for women's health, for pain management.
See, if I was to give advice to a friend, I would say I was told not to do this. And then we know that a lot of people are finding information online. We have a family doctor shortage in this province, and unfortunately, if you can't speak to your physician, your GP, you are going to look for that information, and you usually find it online. How do you inform people who might come in with information they found online that might be somewhat misguided?
Mm-hmm. So Mount Sinai, the Women and Infants program, has some great resources online for a lot of the common questions that come up during pregnancy. So that's a great resource. I think at bottom line, know where you're getting your information from. And I think that's harder and harder these days, but make sure you're getting it from a trusted source. So the Society of Obstetricians and Gynecologists in Canada is a good source. Again, Mount Sinai Hospital has some great resources on their website. So chat with your friends. I mean, always encouraging people to talk to their friends about their experiences too, but make sure you're also, knowing what their source is.
I think I need to put a spotlight on pharmacists because community pharmacies especially are accessible to anybody. Anyone who walks into a pharmacy has access to a pharmacist and can get recommendations and advice there. So
I didn't know that. So you can just go, I can just go to my local pharmacist.
Absolutely.
Okay.
Absolutely. So pharmacists have always been known as the most accessible healthcare professionals because you don't often need an appointment to see them. As long as the pharmacy is open, they're there to consult you. And acetaminophen or ibuprofen may be available or generally available over the counter, so without a prescription. But you can still ask your pharmacist, I'm considering using this medication. What are your recommendations? And they'd be more than happy to give you a recommendation as a first step. If you're if you're waiting for a specialist or a doctor, but you have information there accessible to you.
Thanks for saying that. I think people need to hear that because I think sometimes you kind of feel like you're just on your own, trying to figure out, your health is everything.
Yeah.
You're a one-of-a-kind program in this province and across Canada. Are you hoping that other hospitals will emulate what you're doing?
Yes, there is a huge need for sure. So, we've been talking to people kind of across the country and hoping that our program will encourage others to not be so scared of pregnant people and to support them too. So we're hoping that there, will be some other programs across the country because it's, being in Toronto, it's just not that accessible for so many people.
Yeah. We're really lucky.
Yeah. And I think we need to remind everyone that healthcare professionals across our country are interacting with pregnant individuals. We're not the only center dealing with or interacting with pregnant individuals. Most healthcare professionals are across their practice. So it's been a really rewarding opportunity for us to interact with people across the country who join our sessions and learn from them and understand where are certain gaps and where we can fill them and where maybe we can direct them to good resources, training programs. They sometimes call us directly as well, and we're always happy to provide advice to our colleagues.
Thank you so much for making the time to speak to us about Tylenol and also the normalization of women's pain, especially during pregnancy. Did you have anything else that you wanted to add? Any final thoughts?
Talk to your healthcare team. We are here to support you as a healthcare team in whatever shape or form that may be, whether it's a doctor, a pharmacist, another allied health member. We are here to support our pregnant individuals, and we want to make a plan that works for you. But don't hesitate to reach out because we're here to support you.
Yeah, ask for help. If you're in pain, if you're struggling, ask for help.
And it's nothing you've done.
Yes.
It's normal.
Exactly.
Yeah.
Exactly.
Thank you so much. Appreciate it.
Thank
you
you.
so much.
Thanks. This was Mistreated for October 14th, 2025. You can follow our show on Apple Podcasts so that you can get notified each time a new episode is available. We would love to hear your feedback. You can write me an email at mistreatedpodcast@tvo.org or reach out on my social channels. Here's an email from listener Valerie who writes, Dear Miss Kiwanuka, oh, I love that. Thank you for the episode on endometriosis. Like so many women, I come from a family of 4 sisters where debilitating period pain was, quote, normal in our family. I was shocked to learn that many women with endometriosis have anxiety, depression, infertility, migraines, adenomyosis, and disruptions to other body systems. I will forward a link to your podcast to the women I know. At least the next generation won't have to suffer as much as we did. Thank you so much, Valerie. I love that. And also thinking about making it better for the next generation. We've also had a lot of reaction on Instagram to the episode. Thank you to everyone who has commented and reached out since it went live. This week's episode was produced by Matthew Amara and me, edited by Colin Kish. Additional camera work by Max Stussy. Ariana Longley creates our social videos. Production support from Jonathan Hallowell and TVO's Digital Media Services team. Lori Few is the executive producer of Digital. John Ferry is vice president, programming and content. Special thanks to our studio crew for helping to make the podcast happen. Thanks so much for listening.